This flowchart maps a standard clinical intervention. The red arrow node, labeled technically sound, clinically ineffective, represents interventions lacking cultural context. Ignoring cultural variables risks misreading client needs, which ruptures the therapeutic alliance and causes the clinical pathway to disconnect. Culture shapes how people understand substance use, seek help, and express distress. It also defines their expectations of a counselor and their experience within the helping relationship. Even the most evidence-based, technically precise interventions will ultimately fail if they are applied without accounting for the client's cultural context. Clinicians often encounter two primary obstacles to equitable care. The first is cultural blindness, which occurs when a counselor treats every client identically. This approach ignores relevant data points necessary for effective treatment. The second obstacle is stereotyping. This is the error of treating individual patients as interchangeable members of a broader group rather than as individuals. Cultural humility provides the solution to these errors. It is a lifelong process of growth, characterized by self-reflection and a permanent state of openness. A culturally humble counselor treats the client as the expert on their own life. This shift recognizes that the counselor's expertise must be paired with the client's lived experience. This stance allows clinicians to utilize population-level data while ensuring that the individual in the room remains the primary focus of care. SAMHSA's framework forms a continuous loop around cultural humility. It requires awareness, examining one's own implicit biases, knowledge, learning a population's history and values without stereotyping, and skill, the ability to adapt assessments and clinical interventions to fit the client's specific cultural context. Cultural identity is defined by a matrix of intersecting factors, including age and gender, rural or urban geography, and socioeconomic status. Because individuals are configurations of these intersecting variables, clinicians must evaluate the specific patient rather than relying on generalized assumptions. For Native clients, tribal history and traditional healing are central. Trust is earned across a legacy of harm. For African Americans, care is shaped by faith, community, and the ongoing impact of historical trauma. Integrating a community's historical trauma into the clinical approach changes how a counselor builds the therapeutic alliance. Hispanic and Latino care frequently centers on familismo and acculturation stress. For Asian American and Pacific Islanders, mental health stigma and subgroup diversity are key. Counselors must learn these factors while always prioritizing the individual patient. While population-level knowledge informs the counselor's hypothesis, the individual patient's unique presentation ultimately determines the final treatment plan. LGBTQ+ clients experience minority stress, the chronic strain from stigma and rejection. This pressure elevates substance use risk, but factors like physical safety and identity affirmation provide counterpressure, lowering the risk curve. Clinicians must create affirming environments by using correct names and pronouns, avoiding assumptions about relationships, and connecting clients with community-specific resources. Recognizing the impact of minority stress is required for accurate risk assessment and the immediate establishment of a completely safe clinical environment. Culturally responsive care requires physical and structural access for people with disabilities. These clients face barriers, including inaccessible facilities, communication obstacles, and negative provider attitudes. Counselors must provide accessible materials, like large print documents, and arrange qualified interpreters, communicating directly with the client. Clinicians must challenge assumptions that clients with disabilities are less capable. Access is a clinical, ethical, and legal obligation. Clinical interventions cannot begin until physical and mechanical communication barriers are removed. Effective language access requires the use of qualified interpreters instead of family members. Counselors should speak directly to the client, allow for extra time, and recognize that certain clinical terms may not translate. Providing materials in the client's preferred language and at an appropriate literacy level is a requirement for culturally responsive care. Many clients utilize spiritual beliefs or traditional healing practices as resources for recovery. A culturally responsive counselor incorporates these practices when the client wishes to do so. In-the-room clinical habits include using the client's own terms and asking about the meaning of eye contact, personal space, and silence. The counselor remains curious about what a behavior means to the client rather than interpreting it through their own cultural norms. These adaptive habits represent the practical execution of the skill vector within the SAMHSA triad. Cultural competence is a continuous process. Self-assessment instruments allow counselors to track their growth and identify hidden blind spots in their awareness. Clinical supervision provides a secure environment to examine personal bias and process complex cross-cultural encounters. By eliciting feedback from clients and treating mistakes as opportunities for learning, counselors maintain the humility required for professional improvement. This process focuses on ongoing, honest growth rather than a state of perfection. Cultural competence is an active requirement for clinical efficacy. It demands continuous development and adaptation throughout a counselor's entire career.